Hi, I'm Dr. Marlene Freeman, and I'm going to be talking to you about mastering midlife mood changes with an emphasis on depressive disorders across the reproductive life cycle. I'm a professor of psychiatry at Harvard Medical School and a psychiatrist and the associate director at the Center for Women's Mental Health at Mass General. So when we think about the reproductive life cycle in women, starting with the first period or menarche, through woman being postmenopausal, we think about different times of vulnerability for mood and other psychiatric disorders across that reproductive lifespan. We know that women across the reproductive years are at greater risk of major depressive disorder than men are. And it's pretty pronounced. It's about 2 to 1. So women are at much greater risk of not only mood, but also most anxiety disorders. Now, there are particular times that women may be especially vulnerable to experiencing psychiatric symptoms like depressive symptoms or mood symptoms or anxiety. And some of those may be related specifically to times of hormonal transition. So times such as the postpartum where hormones are shifting, the menstrual cycle, many women experience changes throughout the cycle, especially premenstrually, and then in the perimenopause or time leading up to menopause. So for many women, disorders are often chronic or recurrent and really lifelong. So the goal can be managing them, but for many women, it's something that they deal with throughout their lives. So psychiatric disorders have been called chronic illnesses of the young because we appreciate more and more that children and adolescents often have onset. So even though disorders are often not recognized till later, some women do recall having the onset of depressive episodes or anxiety very early in life. For some women, that may not be the case. They may experience the first episode of depression postpartum or during menopause, where there is an increased risk of time of new onset depression. But for many women, it's something that they have been struggling with from early on and may experience differently across the reproductive lifespan. So just to take a step back, what we're talking about when we talk about depression or clinical depression or major depressive disorder, we're talking about at least 2 weeks, although it's often a lot longer, at least 2 weeks of someone feeling persistently low or depressed mood or loss of interest or pleasure in things with some other symptoms, like could be changes in appetite, changes of sleep, either more or less, decreased energy or feeling agitated or anxious, trouble concentrating. Some patients have suicidal thoughts. So there are an array of different symptoms that some individuals might have, but they are basically persistent for at least a 2-week period. Now, we often have to consider what other diagnosis might be presenting. So some individuals have bipolar disorder, which is characterized not only by depressive episodes, but also episodes of mania or hypomania, or someone may be persistently up or energized for days in a row. Maybe someone doesn't need a lot of sleep for days in a row, does things that are impulsive or out of character, but definitely has episodes that are more up or energized that are also persistent. We want to consider family history when we're thinking about diagnoses because some disorders run in families where there's a greater risk. It doesn't mean that they're always passed along, but there may be a greater risk. Anxiety and depression can often co-occur together or separately, and in a snapshot, a depressive episode may look like anxiety. We also want to rule out medical conditions if someone is experiencing some of these symptoms. So for example, hypothyroidism or thyroid disorder can share some of the symptoms as depression. Now, we're appreciating that women are having children at older ages. So partly it's because they're deferring pregnancies. Many women are pursuing their education and starting careers and pursuing pregnancy later. And for many women, they're able to conceive because of infertility treatment. But we do appreciate that there's a growing category of women having children over the age of 40. Half of pregnancies in this country are unplanned or mistimed. So it's really important that if someone is even perimenopausal, that they're using some form of contraception if they don't want to conceive. So many women think that they can't get pregnant, but it's often not the case. So it's not uncommon that in the late 30s and sometimes early 40s, we see women with surprise pregnancies. So for women of reproductive potential, we want to make sure that they're taking good care of themselves. If they do have a pregnancy, that it can be the healthiest as possible. And that if they're not trying to conceive, if they do not want to have a baby and get pregnant, then we want to make sure that we're always thinking about contraception. So even if someone thinks they may be too old to conceive, they may be wrong. For more information about some of these topics in more depth, because I'm just giving you some highlights today, we have a website at our center, which is www.womensmentalhealth.org, with more information about all the topics that we're talking about today. Now I'm going to just touch on the menstrual cycle and mood changes that can go along with that, because many women notice this occurring in midlife, even more notably than earlier in life, sometimes for the first time, sometimes in our clinic, we hear that after women have children, they notice more premenstrual symptoms. So when we're talking about premenstrual mood changes, we're talking about premenstrual syndrome, which is PMS, which most women will have some symptoms of. That includes physical and emotional symptoms, but it's generally mild and doesn't impact functioning. As a diagnosis in psychiatry, we have premenstrual dysphoric disorder, which is severe enough symptoms of mood and other symptoms that occur in the premenstrual phase or the luteal phase of the menstrual cycle, so before one gets her period, that is so distressing or severe that it interferes with functioning. So either work or social or relationships, in some way a woman is not functioning as she would in her normal life. And then we also have to think, if someone is reporting more mood symptoms premenstrually, what else could it be? So many women who have mood disorders notice premenstrual mood worsening. So it's important then that the whole picture get appreciated so that the care is really holistic and comprehensive. So the symptoms that may occur are not very specifically to PMDD. So you can see depressed mood, anxiety, mood changes in general. A lot of the things that overlap with depression, but what makes PMDD so specific and its own diagnosis is that it is the temporal occurrence. So it occurs during the luteal phase or premenstrually before onset of menses, and gets better either with onset of menstruation in the cycle or soon after it starts. So it's cyclic according to the menstrual cycle. The symptoms usually start in the 20s, although for many women, we see them become more pronounced in the 30s or 40s, and they are not at all uncommon in women in their 40s and leading up to perimenopause, so, or through perimenopause, I should say. So for many women, they struggle with these, sometimes notably worsening as they are going through perimenopause. So most consistently, women complain about anxiety, irritability, mood changes or lability, regulation problems. We often hear women feel fuzzy or have cognitive problems. There are other symptoms that may be related. So what we really want to do in terms of making the diagnosis and having a woman really understand how her cycles affect her mood are have her do prospective charting. So either using an app or a calendar where she keeps track of mood and menstrual cycles. So this could be just on a paper calendar where someone circles the days that they have their period and makes notes across the month on mood changes. And then you can look, across time, is there a pattern or not? Now, the treatments include antidepressant medications, specifically those that affect serotonin, like selective serotonin reuptake inhibitors, like SSRIs. Those are commonly used, and many are indicated by the FDA for the treatment specifically of PMDD. Now, some women may be on them for depression and also use them then for premenstrual worsening. But for women who only have premenstrual symptoms, there are some options in terms of dosing. So they sometimes seem to get by with lower doses than are typically used for depression. They can sometimes use them across the cycle, so every single day, or sometimes in a more targeted way, so just during the premenstrual phase. And so it really depends on the individual, how regular her periods are, and how sort of circumscribed those symptoms are to that period of the cycle. The other treatment that has received FDA approval are oral contraceptive pills. So some oral contraceptive pills, the combinations of estrogen and progesterones, have been approved. There are some that are FDA approved, although benefit is not uniquely related to those that are FDA approved. It's just that some companies went for the indication. But one woman may do very well on one pill and not another. So sometimes we have to try out different types of pills. And they're also prescribed in different ways. So some are prescribed where women get a pack per cycle and get 1 week of placebo. So she has a menstrual bleed at once a cycle. And some women have what we call continuous dosing, where basically the pill packs are run together, where she skips the placebo week and maybe has fewer periods per year, like 3 or 4 periods per year versus once per cycle. Now, so in terms of the treatment for premenstrual mood worsening and PMDD, the first line treatments are really antidepressants and oral contraceptives, which are the best studied and most robust for severe disorder. But also some other things that have been shown to be helpful in some studies include exercise, a focus on healthy nutrition, decreased processed foods, more whole foods. Omega-3 fatty acids have been looked at as an add-on strategy, and also calcium supplementation has been looked at. But truly, in terms of the more robust responses for women who are suffering, the antidepressants and the oral contraceptives appear to be the most helpful. Now, switching gears, the menopausal transition. So the perimenopause is the time leading up to menopause, so where women may start having irregular periods or hot flashes. And we define the postmenopause as when someone has had more than a year of no menstrual cycles without any other reason for not having them. So sort of a natural cessation of the menstrual cycles for more than 1 year. Now, the perimenopause is characterized by clinical symptoms, so irregular periods. The majority of women will have hot flashes or vasomotor symptoms, where they might feel like very hot in short periods of time, or they might have night sweats, is also commonly reported. Sleep disorders or sleep disturbance like insomnia are very common. And there is an increased risk of major depression onset in women during perimenopause, even if they have not had it before in life. We do see an increased risk. So we do know that some of these symptoms are attributable to changes in hormones. So we know that women do have hormonal variability across the perimenopausal transition. And some studies do show that with more hormonal variability, some women will have more symptoms. But it's not the whole story, because every woman who goes through perimenopause is experiencing some hormonal variability, but not every woman will have major depressive episodes. So we don't fully know what accounts for that risk in some women. Now, it's been proposed that there's a domino theory of menopausal depression, where there are estrogen fluctuations and decreases that lead to hot flashes, which then may cause insomnia or disrupted sleep, and then may worsen depression. But it's also suggested that changes, actually the variability in estrogen levels, may itself have an impact on mood. So being one of those times in life that can be especially vulnerable to women. So another thing that's really important for us to screen for in women who are complaining about perimenopausal symptoms and feeling fatigue or depression or insomnia or daytime sleepiness is to screen for sleep apnea. So where breathing is disrupted during sleep, which means that individuals with sleep apnea can't get good, deep, restorative sleep. So many individuals who have sleep apnea will snore. There are a lot of health risks that are associated with sleep apnea. So including some of the psychiatric symptoms that we talked about, increased risk of cardiovascular problems, and people generally just don't feel good when they're not getting good sleep. So we can screen for it. Sort of the easy version is to ask someone if they know if they snore, if they have a partner that can report if they snore or not, because that makes us really suspect sleep apnea. But if we do suspect sleep apnea, them, and sometimes it's related to weight, but even thin people can have sleep apnea. But if we do suspect it, then we generally recommend that someone have a sleep study. It is treatable, so some patients can get breathing machines or CPAP machines to help make sure that their airway stays open during night, which helps improve the quality of sleep. And for some patients, they may be able to make some lifestyle changes like weight loss, which is of course easier said than done. And the risk factors include being overweight, older age, smoking, and then menopause or perimenopause is also a risk factor. So estrogen is often prescribed around perimenopause. It is the gold standard for severe hot flashes, but it may also have an impact on mood. So there are a number of studies that do show an antidepressant effect of estrogen, but it's just not well studied as a monotherapy or standalone treatment for major depressive disorders. So typically in the literature and studies, we see estrogen added on to antidepressants if someone is experiencing major depressive disorder around menopause. So in terms of the treatments that we have for menopausal depression or perimenopausal depression and hot flashes, some of these overlap. So in women who are not able to take estrogen or hormones specifically for perimenopausal symptoms, antidepressants, specifically serotonergic antidepressants, those that work on serotonin, have been looked at specifically for the treatment of hot flashes. So in women who can't take hormones for some reason, maybe increased risk of breast cancer or history of breast cancer, for example, antidepressant medications are often used to treat hot flashes. That they're commonly used, and several of them have been shown in very well done studies to be helpful. Hormonal therapy may have some benefit for depression and is really, as I said, the gold standard for severe hot flashes. There's also a medication called gabapentin, which is had the brand name Neurontin. It's now available generically, which is often used. It's used for seizure disorders. It's used for some pain disorders. It doesn't have FDA approval specifically for a psychiatric disorder, although we do see it commonly used for treatment refractory anxiety. But there are randomized controlled trials supporting its effect on hot flashes. So it is not FDA approved for hot flashes, but there is scientific evidence that it does help with hot flashes. Now, the main side effect of it is that it can make people sleepy. So sometimes if people are really stuck, they've tried other treatments that haven't worked, then sometimes gabapentin can be particularly helpful for both nighttime hot flashes and for sleep. Sleep medication, there have been studies specifically for women who experience nocturnal hot flashes using sleep medication. Interestingly, it does not appear that the sleep medications take away the hot flashes, but if women can sleep through them, they're just less bothered by them. And then there's mixed data with the supplement omega-3 fatty acids, both for mood and for depression, where primarily the antidepressant benefit has been as an add-on treatment to more standard antidepressants. And there are some studies showing that there could be a benefit for hot flashes, but other studies showing no benefit for hot flashes. So probably not one of the more robust treatments. So to summarize, we know that women are greatly impacted by mood disorders across the reproductive lifespan. They're at greater risk than men. The difference is most pronounced during the reproductive years. And there are special considerations around reproductive events like pregnancy, postpartum, the menstrual cycle, and perimenopause, with a special focus on some diagnostic considerations, how the different disorders may present and with what sort of accompanying symptoms. So, it really, requires, a careful look at all the symptoms a woman may be having and what stage of life she's at. So for more resources, I refer you to our website, which is www.womensmentalhealth.org, which is our Center for Women's Mental Health at MGH. And also for more information, the Depression and Bipolar Support Alliance and the National Alliance for the Mentally Ill, both of whom have websites that include a lot of information for patients and their families. Thank you so much for your interest in the presentation today. I really appreciate being included. Thank you.